Good morning, my dear students. We have seen in the last few lectures how the anatomy of the nasal cavity, which starts from the anterior nares to the posterior nares, the roof, the floor, the medial and lateral walls, and how the nasal cavity is divided into two by the septum, and each right and left nostrils and we have seen how the nasal cavity is divided into spaces by these three projections which are coming from the lateral wall of the nasal cavity, which are called the turbinates. And we have also seen in the anatomy the lining of the nasal cavity, which is primarily of three varieties. Anteriorly, the skin lined, which is called the vestibule, and the major part of the nasal cavities and the paranasal sinuses are supplied by an epithelium which is called respiratory epithelium, which is otherwise called pseudostratified ciliated columnar epithelium. Then you have a third variety of mucous membrane lining in the roof of the nasal cavity, almost at the roof and above the superior turbinate level, and the corresponding area on the septum, which is the olfactory mucous membrane. And we have also seen how the turbinates, which project, increase the surface area of the mucous membrane of the entire nasal cavity. And this basically, the mucous membrane, as we have discussed, consists of the pseudostratified ciliated columnar epithelium, the cilia which are there, and we have seen the function of the cilia, how the mucociliary clearance occurs, and the submucosal glands are the ones which they produce the mucus, and this mucus in turn, how it helps in the functioning of the air conditioning of the nasal air that is passing through the nasal cavity into the lower respiratory tract. So we have seen the various functions of the nasal cavity, that is the physiology in the nasal cavity, the olfactory sensation, the humidification, the temperature regulation, and the filtration, and the mucociliary action, and how it helps the air coming in, breathing in and breathing out, how the various paranasal sinuses are ventilated. So that is about the physiology of the nasal cavity. So that is the basic anatomy and physiology. And now we have seen that because of various conditions, either because of a inflammatory, traumatic, neoplastic, or some congenital conditions, and or some miscellaneous conditions are the ones which alter the nasal cavity anatomy. They have some kind of an effect on the mucous membrane lining, how they damage the mucous membrane, the traumatic, inflammatory, neoplastic conditions, and bring about some changes in the anatomy, and which in turn reflect on the physiological functions of the nasal cavity. So today we are going to deal with a condition called atrophic rhinitis. This atrophic rhinitis, basically atrophy means a degeneration. Now, atrophic rhinitis, in the sense, there is degeneration of the mucous membrane. So, the degeneration of the mucous membrane, in the sense, the ciliary function is interfered with, the mucosal gland secretions, mucous glands are damaged, so there is no mucus production or a decreased mucus production, and how it affects the air conditioning and also the mucociliary clearance. So when there is atrophy of the nasal mucous membrane, it brings about the changes which to some extent interfere with the normal physiological functions and produce a condition, a diseased condition. So today's condition is the atrophic rhinitis. This condition, wherein there is atrophy of the nasal cavity, nasal mucous membrane, for various reasons. We'll discuss the various reasons why the atrophy occurs, and I'll tell you the basic pathophysiology of this atrophic rhinitis. This is basically the interference with the blood supply of the nasal cavity. What really happens in the blood supply of the nasal cavity is there is a endarteritis or periarteritis. That means the blood which is carried in the arteries and arterioles, there is a endarteritis produces decreased blood supply, and there is another condition in the atrophic rhinitis. There is sometimes a increased blood supply. So both these conditions, the commonest is the decreased blood supply because of the narrowing of the arteries, so which is called the endarteritis. Now there is so the atrophic rhinitis is classified into two varieties, which is number one is the primary, where definite cause is not very well established, but there are certain factors which are considered to be influencing the process of the atrophy. And there is another variety which is called secondary atrophic rhinitis. Secondary atrophic rhinitis, where there are some conditions where there are which bring about this kind of arthritis or decrease the blood supply, like the inflammatory process, the traumatic, or some kind of a deviated septums which make the mechanical obstructions. Now this, if you go into the history, Dr. Spencer Watson in 1875 used the term rosine, which means bad smell. And later Dr. Bernard Frankel in 1876 described the triad of fetor, that is the bad smell again, the crusting. The crusting means the mucus, the crusts are basically the mucus that is being secreted becomes thick and dries up. That is called a crust. So the crusting occurs. And then the third one is the atrophy of the nasal structures, particularly atrophy of the nasal mucous membrane, and it also involves the various lateral wall of the nasal cavity, which consists of the turbinates, how the ethmoid bone, the bulla ethmoidalis, the lateral wall of the nasal cavity, how it changes or atrophies. There is a bony atrophy also. So that we will see how it happens. Now, basically the pathophysiology is chronic inflammation of the nose with progressive atrophy of the nasal mucosa, and terminates the mucous membrane as well as the bones, and formation of scanty viscid secretion. These secretions, because as we have seen, the mucous membrane, the submucosally, the glands which are there, the goblet cells, it secretes the mucus. they are also decreased, and so the secretion, amount of secretion that is produced becomes reduced, and there is these secretions become dried up, they become thick, they form green crust, and on these crusts there is a secondary infection which gives rise to bad smell. And the removal of these crusts reveal roomy nasal cavities, alright, because the crusts are the ones initially which block the nasal cavity, and once these crusts are removed, the nasal cavity becomes very roomy. And also sometimes there are some episodes of bleeding that occur when the crusts are removed, because they are adherent to the nasal mucous membrane. Now, as I told you, the primary atrophic rhinitis, where the etiological factors are not very definite, to some extent contribute, and this is either a developmental, sometimes it runs in families, and endocrine, because it usually affects the females, and during puberty, menopause, and during menstrual periods, and some of them racial, and some nutritional deficiencies which are usually because the vitamin A, vitamin D, and sometimes iron deficiency, anemias also produce this. Then infections, various kinds of infection, the organisms have been incriminated. The autoimmune, basically what happens in an autoimmune disorder is there is some kind of a infection, either viral infection, which alters the nasal mucous membrane, the protein, and so the body tries to produce some kind of antibodies to our own cell system. That is called the autoimmune system, and that keeps destroying so viral infections which alter the nasal mucous membrane and make those tissues as foreign bodies to our own system, and so the body tries to destroy them. So that is the autoimmune disorders. And the autonomic balance, as we know, if you see the nerve supply, there are two kinds of nerve supplies. That one is the sensory, which is by the anterior ethmoid, the ophthalmic branch, and the maxillary. Then you have the second kind of nasal, the nerves which are called the autonomic nervous system, wherein you have the sympathetic and parasympathetic. And this autonomic nervous system is brought into the nasal cavity by the pterygopalatine ganglion, where you have the sympathetic and parasympathetic. What they do is parasympathetic is secretomotor, whereas sympathetic is the one which reduces. So there is an imbalance between these two, and so the secretions are decreased. Then the surfactant deficiency is another factor, which is so in the nasal secretion, which helps, or which is the one which is responsible for the mucus to move, nasociliary function. So if there is a deficiency of this, nasal secretions get collected there, and they become a crust, and this crust invites the bacteria, and also the crust is the one that slowly becomes hard and partially responsible for the nasal obstruction. So these are the various etiological factors for a primary atrophic rhinitis. Then we go to another, these are all developmental, to go a little into the details. Congenitally, spatial nasal cavity developmentally, and poor pneumatization of the maxillary antrum, and so maxillary antrum is small, so the nasal cavity becomes wide. Then you have the hereditary factors caused by autosomal inheritance, and 67% is the dominant, and 33% is the recessive. Then, as I told you, the endocrine, the hormones, particularly the estrogen, how during puberty, menopause and menstruation they have their role in producing these atrophic rhinitis. Then of course the racial, where more in American Negroes and Latin races, and nutritional deficiency, iron, vitamin D, vitamin A deficiencies, and the infection wise, the Klebsiella ozeni or Coccobacillus foetidus and Bacillus mucosus and diphtheroids, Haemophilus influenza. These are the various infections which are associated with the atrophic rhinitis. And as I told you, the autoimmune conditions, the trigger destructive autoimmune process on the nasal mucosa, and autonomic imbalance, and the surfactant in the nasal secretion deficiency, which impedes the ciliary function, and so there is stasis of nasal secretion. So that is about the primary atrophic rhinitis. Then we go to another condition called secondary atrophic rhinitis. Means this is usually because of chronic inflammatory conditions, and the syphilis, leprosy, and the lupus vulgaris. These are the conditions which are called chronic granulomatous conditions. Chronic granulomatous conditions. All these chronic granulomatous conditions, the pathology the pathology is endarteritis. Endarteritis, as I told you, the arteries, the wall of the arteries becomes thickened, and so the blood flow becomes small or reduced. And when there is no blood flow, that is the one which takes the nutrition to maintain the mucous membrane normally. So when this is decreased, there is decreased, the mucous membrane gets damaged, and the submucosal glands also get damaged, and also the bone also gets absorbed. So these are the chronic granulomatous conditions which are. And secondly, iatrogenic, in the sense we as surgeons, when there is an obstruction of the nasal cavity or a deviated septum, we would like to make a passage in the process, being over enthusiastic. We feel that the turbinates are the ones which are narrowing the nasal cavity, forgetting their normal function, the physiological, how they assist in the physiological functions of the nasal cavity, which are very important. If somebody comes with a nasal obstruction, we try to resect these tissues, not totally understanding the complications of resection. We are only concentrating on establishing the passage, but we forget the function of the turbinate, which helps to a major extent, as I told you, venous sinusoids, how it helps in the regulation of the temperature, and also the mucous membrane, which is the one which covers the turbinate, and which in the nasociliary function, as well as the humidification by the secretion of the mucus that is produced submucosally. So all this is removed, and so there are the conditions where iatrogenic, after taking away of these turbinates, either inferior turbinate or middle turbinate, they produce inflammatory, the atrophic rhinitis. Then there is another condition which is gross deviation of the septum. One side, the entire nasal cavity is so roomy, okay? So roomy, and so that is the one which predisposes for the atrophic changes that may occur during that time, because of that. So this is what it is: long-standing purulent sinusitis infections which alter, and the iatrogenic turbinectomy, maxillectomy, post radiotherapy, and conditions we have seen: tuberculosis, syphilis, leprosy. and rhinosclerum, and gross deviation of the nasal septum, and with a wider nasal cavity on side. Now, the long-standing purulent sinusitis, how it contributes to the production of atopic rhinitis is, as you know, there is during infection, the chronic infections, the inflammatory process which is continuously happening and produce the chronicity wherein the mucous membrane, the nasal mucous membrane or the maxillary sinus mucous membrane becomes altered into another kind of mucous membrane which can resist the infection, alright, which is called the metaplasia. This metaplasia is transformation of the ciliated pseudostratified ciliated columnar epithelium into the squamous epithelium. The squamous epithelium, it resists, squamous epithelium resists the infections, alright, but it cannot function the normal functions of the nasal mucous membrane, that is the mucociliary clearance and the production of these mucus. So, long-standing infections, that is how they contribute to the formation of atopic rhinitis. Then the various symptoms with which the patients come to you. How do they come? They come with a nasal obstruction. This nasal obstruction, various factors are involved in this. Nasal obstruction may be because of the nasal crusts that form, nasal crusts, and they are the ones which obstruct the nasal cavity. Then they may come with a complaint that when there is an obstruction and when they blow, there is a greenish yellow nasal discharge. Sometimes the crusts themselves fall. With a bad smell. This bad smell is to the people around, but they themselves do not have the sensation and the perception of smell. That is called merciful anosmia. Merciful anosmia in the sense the patients cannot smell their own bad smell, the feature which other people around them perceive. Then, of course, as I told you, the crusts which are found on the mucous membrane, when they get dislodged, they produce a kind of ulceration on the mucous membrane, and that is the place where there may be ulceration and the blood vessels, sometimes small blood vessels, rupture and then produce the epistaxis. So these are the various symptoms with which a patient comes to us. One is people, the bad smell. They don't smell the bad smell, but people around, and they themselves have this anosmia. They cannot smell, and they come once again with a complaint that the whole thing is dry. My nasal cavity is very dry, and sometimes when you do the examination or when they blow, there is the crust, nasal crust. These are the nasal crusts, and which are formed, which obstruct the nasal cavity, and the crusts fall off, and then they produce what is known as the bleeding, epistaxis. And of course, the nasal obstruction, they keep on using the nasal sprays in order to reduce the nasal obstruction. So these are the various symptoms with which the patients come to you. Then we go to the signs. So when they come with these kind of complaints, so our examination primarily is to look at the nose if there are any deformities, because if there is too much of destruction of the nasal terminates on sometimes nasal septum as such. There is a depressed nasal pyramid, nasal dorsum. So the examination, sometimes you may see the deformity. Then when you examine the anterior rhinoscopic examination, you will see that the nasal cavity is so roomy, and sometimes you can see right up to the nasopharynx. You can see the choana, and then nasopharynx. Sometimes when they swallow, the soft palate movement can also be sometimes appreciated. That means the entire nasal cavity becomes very roomy, okay, because the turbinates they become very small, and atrophy of the mucous membrane. Then sometimes when you do a anti-rhinoscopy, or sometimes when you do a endoscopy, nasal endoscopy, you need to see the greenish yellow nasal discharge with the crust formation, as we have seen in this picture here. Sometimes they are anterior, sometimes they are posteriorly situated. And then, of course, the foul smell is something which you perceive, and the nasal septum, sometimes because of chronic inflammatory process or endarteritis themselves, the septal cartilage also gets necrosed and produces a nasal perforation. And of course, the nasal myiasis, wherein you have the maggots. Maggots usually are the ones which are nothing but the eggs that are laid by the fly. They become these maggots, and they are present in tissues where there is a lot of dead tissue. So that is called nasal myiasis. Now, normally, if you take a picture of the coronal section, which is done like that, you will see the nasal septum in the midline, and the orbits, the maxillary sinuses, and the middle, the superior and the middle turbinates. This is the bulla ethmoidalis, and this is the inferior turbinate. This is the ethmoidal complex. This is the ethmoidal complex. This is the normal structure. The passages are narrow like that, and that's the maxillary sinus. This is the normal section. This the picture which you see in a coronal section. Then the same thing that you see in a atrophic rhinitis. You see this the maybe superior turbinate not seen, and smaller. This is the middle turbinate. Okay, and the bulla ethmoidalis is atrophied. The unsnate process is atrophied, which is in the lateral wall, and this is the inferior turbinate. See how not only the mucous membrane, but also the bone, the turbinate bone itself shrinks, and so there is a wide nasal cavity that is there. This is this defining that way. Now, the different diagnosis for bad smell. Okay, the atrophic rhinitis and purulent sinusitis, nasal foreign body. There is a foreign body that also produces bad smell. Rhinitis caseosa, condition where there is thick, which is otherwise called cholesteatoma of the nasal cavity. And of course, in malignancy, where there is a lot of dead tissue, and so it attracts the bacterial infection, and which in turn produces the bad smell. Now, for dry nose atrophic rhinitis, the rhinitis sicca, wherein usually this is found in people who are working in in the kitchens where there is a lot of heat, and some of these refineries, the industries where there is a lot of hot air that is coming out, and such people usually have this rhinitis sicca. And there is another condition which is called Sjogren's syndrome, rhinitis sicca, okay, associated with other conditions. Then, of course, radiotherapy is another one for patients who are receiving radiotherapy for a malignancy. In such conditions, also radiotherapy decreases or produces endarteritis and decreases the blood flow, and so produces this atrophic rhinitis. And then that is about the physiological function as far as the mucociliary function and the temperature regulation and the filtration is concerned. Now then we go to the olfactory epithelium, which I said is situated almost the roof levels above the superior turbinate, and usually the normal structures are the cells with their cilia, how there is a small mucus layer into which the odorant particles come and then they dissolve, how there is a neurological activation takes place, and how it is conducted via the cribriform plate into the olfactory bulb. That we have seen in the physiology of the nasal cavity. That is the normal mucous membrane. That's the non-mucous. And if because of these endarteritis, as I told you, is the major factor, produces destruction of these mucous membrane and also the nerve cells, and so the nasal, the perception of smell, the olfaction is totally not perceived. That means anosmia. So it is either because of this anosmia, maybe because of the atrophy of the mucous membrane, atrophy of these various neuronal cells, or sometimes it may be because the atrophic rhinitis, as we discussed, produces nasal crests which do not allow the air to pass into the olfactory region. So these are the various causes for the anosmia that is produced. Now this is what it is. The olfactory neural elements are destroyed, and thick secretion crusts over the olfactory area, and degeneration of the secretory glands, and those are the various causes for anosmia. And these people, they complain that there is a obstruction to the nasal cavity. This feeling, which is otherwise called sometimes the empty nose syndrome, where there is a blunting of sensory nerve endings. See, actually these are the ones which detect the airflow, and so that sensation is lost because the nerves themselves are destroyed because of the atrophic process. And there is the crust formation is another, and the lack of eddy currents. Last time we have seen how the eddy currents are produced during inspiration and expiration, particularly when the air passes through the nasal cavity. These turbinates and of course the nasal valve, those are the ones where there is a obstruction to the free outflow of the exhaled air, and so there is a kind of a circulatory movement in the nasal cavity which called the eddy currents, and these currents are the ones which ventilate the paranasal sinuses. The pathology, as we have already told you, the accumulation of the lymphocyte plasma cells, inflammatory and squamous metaplasia that takes place from the ciliated columnar epithelium transforming into the squamous epithelium, and decrease in the nasal glands and bone resorption. And so there are two types: endarterectomies, periarterectomies, and terminal and which benefit by estrogen therapy. The type 2 dilated capillaries worsened by estrogen. Then if you take the biopsy of these nasal mucosa, these are the cilia normal, and the secretory glands. Okay. Now these cilia are totally lost, and there is a stratified squamous epithelium which is there, and the loss of glands, some mucosa. This is the finding in the ectopic rhinitis. This is normal mucosa. Then there are certain investigations which will help us to find out the functions of the nasal cavity. That is the saccharin test, where you dissolve sweet, the saccharin, in the water and place it on the anterior end of the inferior turbinate or in the floor of the nasal cavity. In about 10 to 15 minutes, because of the nasal mucociliary activity, the saccharin is pushed backwards and comes into the nasopharynx, and you can feel the sensation of sweet sensation. This takes about 10 to 15 minutes. So in these conditions, because of nasal mucociliary clearance is not properly happening, there is a delay. Sometimes it takes a very long time for the saccharin to reach the nasopharynx. Then the iron deficiency, the various vitamins that are responsible in the primary etiological factors or the primary ectopic rhinitis. Then of course the various organisms that we have mentioned also can be cultural insensitivity can be done. Diagnostic nasal endoscope, where you would like to see the widening of the nasal cavity, turbinates, hypertrophy, the bulla ethmoidals is shrunken, the lateral wall is totally pushed lateral, and there is and certain investigative procedures radiologically, you will see that there is the thickening of the mucoperiosteal layer, and this is the middle turbinate, so the bulla ethmoidals has to be somewhere there, projecting or producing a bulge that is also destroyed, and there is the unsnake process. Unsnake is not absolutely, it's totally destroyed, and if you see the maxillary sinuses, they become very small, hypoplasia, and if you see the nasal cavities, they become roomy. Okay? So there is the entire lateral bowing of the lateral wall of the nasal cavity, and the inferior turbinate is almost destroyed there. You don't see the inferior turbinate. Then the investigations are to find out chronic inflammatory conditions and infective conditions, and the serology for syphilis, and sputum for AFB anti-test, nasal smear for the bacillus leprae, and for the rhinoscleroma is another condition which also produces the dryness of the nasal cavity. Now the medical treatment is basically the various solutions, nasal sprays, and regular cleaning of the nasal cavities, some antibiotics, sometimes the placental extract injections, and the antibiotics and Mandel's nasal paint which consists of potassium iodide, estradiol, and that is everything. Now, nasal irrigation is the most important mainstay of this medical management, wherein either the normal saline, which is there is a procedure where you can allow the water, normal saline, to go into one nostril and come out through the other nostril. And in the process, what they do is they dissolve the crust, and the crust get released, and so the passage becomes normal. It also gives the humidity to the nasal cavity, so that there is a regeneration of the nasal mucous membrane to help with the regeneration of the mucous membrane. And of course, there is a solution called the combination of sodium bicarbonate, which loosens the nasal crest, the sodium biborate, which is an antiseptic, and the sodium chloride makes the solution isotonic, so that there is no irritation to the nasal mucous membrane. All of them mixed in 280 ml of warm water, and you do the irrigation like this. So the crust come out, there is humidification of the nasal cavities, which helps in the regeneration of the mucous membrane, and the infection is regularly being cleared. This has to be done regularly, every day, just like you brush your teeth. So it should become a habit for these patients. And that is the various other methods of medical management is the progesterone, estrogen, and some of these biogenic stimulator metabolic and regenerative process, the mechanical narrowing of the nasal passages, which usually come in the surgical procedures. Now, surgical procedures usually, there are various surgical procedures that have been employed in this. The types of surgeries. One is basically you would like to close the nasal cavity totally, which is called Young's operation, you will see. And modified Young's, how it is the same similar operation, but there is a small modification which helps a certain advantage where there are certain advantages. Then the surgical procedures which reduce the volume of the volume of the nasal cavity. Okay, and this reduction of the nasal cavity is done by certain procedures like Lawton Slager, who described medialization of the lateral wall of the nasal cavity, and Wilson, of course, the submucosal injection of the Teflon paste, where ultimately they reduce the amount of nasal cavity, that roomy nasal cavity is reduced. And sublabial implants, once again same, various implants are used. And vestibuloplasty, where you reduce the airflow into the nasal cavity. And there are certain procedures which are called the denervation, that is, as I told you, the sympathetic and parasympathetic are the ones which are responsible for partly responsible for the reduction in the secretory cells, and so produce atrophic rhinitis. So the sphenoid and ganglion block, these are the ones which to some extent help in the increasing the sectomotor fibrous stimulation and the regeneration of the mucous membrane. Now, salivary irrigation, therapeutic duct, sometimes if you are trying to provide the mucous membrane humidification, this is done by the duct, Roentgen's duct, which is directed into the maxillary sinus. So basically providing for the humidity or the mucus, instead of the mucus, because the nasal mucous membrane cells are damaged, the mucus is not produced. So this is one way to divert the salivary secretion, therapeutic secretions into the nasal maxillary sinus and thereby into the nasal cavity, which helps in the regeneration of the mucous membrane. Now we will go a little deep in detail about these procedures and try to understand how they are done. Now, surgical treatment. This is Young's and modified Young's. These are the mainstay of the surgical procedures. This is the normal anterior nares with this columella, and that is the nasal valve area, and there. You raise the flap all around on the septal side as well as the lateral aspect, and then you suture thereby closing the entire nasal cavity. Then that is, and after 6 months or 1 year, this is released, and they found that there is some kind of a regeneration of the atrophied mucous membrane, nasal cavity mucous membrane, and it is done on the other side, and usually similar procedure, 1 year to 1.5 years is blocked around. Then they found that there is the Young's operation when it was totally blocked. You can do only on one side. You cannot close both the nostrils at a time. So one after the other. Here, Young same surgeon has modified. They're keeping a small aperture in the closure, and so the air goes through this nasal aperture and goes into the nasal cavity. There are certain advantages of this small aperture, when the air goes through the nasal cavity, through these small apertures, it goes into the roomy nasal cavities, and so there is a phenomenon called the Bernoulli's phenomenon, when air passes through small passage and suddenly expands. It lays down whatever is the moisture that it has on the mucous membrane there, so which helps in the regeneration of the nasal mucosa. And the other advantage is you have a small aperture there through which you can pass 2.5 mm endoscopes and visualize the nasal mucous membrane, and if there are any crusts, they can be washed out or cleared. So another incision. This is what is the modified Young's operation, where there is a mucopericardial flap that is elevated medial, lateral towards the inside, and it is closed in layers. And the advantages of this modified Young's operation is disease can be monitored with 2.5, as I told you, nasal endoscope. The glucose and glycerin drops can be instilled into the nasal cavity. Both nostrils can be operated one sitting. Nasal breathing is preserved. No complaints of the nasal complete total blockage of the nose. Better cosmetic results also. Then surgical treatment, as I told you, the various other procedures wherein we will go rapidly. into. This is the nasal cavity. Lateral wall of the nasal cavity above is separated by the cribriform plate, whereas below it is the maxillary sinus. So the maxillary sinus wall is the one which is pushed medially. This is the Lawton-Slangus operation, wherein the nasal cavity, as you see, such a wide, roomy nasal cavity becomes narrow, and there is the Wilson's operation, where procedure where you inject submucosally the Teflon paste, and so the wide nasal cavity becomes narrow, and then you have these sublabial implants into the nasal cavity, into the floor and the medial wall, and the vestibuloplasty, where you reduce the amount of air that is flowing partial blockage. The antral mucosal transplant is another surgery where the maxillary antrum sinus mucosa through a small opening in the inferior meatus is opened up, and so this mucosa slowly grows into the nasal cavity. And these are the various types of surgical procedures as we have summarized. Nasal closure, Young's operation, modified Young's operation, where there is a small opening that is created. Lawton-Slangus, lateralization, medialization of the lateral wall. The Wilson's, narrowing, the sublabial implants, the vestibuloplasty, which reduce the nasal cavity. And denervation, various sympathectomy, cervical sterate ganglion block, sphenoidal ganglion block, and salivary irrigation by duct implantation. Now these are the various ways in which the atrophic rhinitis is being treated. So this is ultimate aim of these surgeries is to reduce the volume, basically closure, and of course the supplementation of the secretions, and increased vascularity in nasal mucosa by denervation procedures and implantation of maxillary sinus mucosa by the parotid duct. So these are the surgical procedures. So there is a small mnemonic which you can remember these various surgical procedures. And maybe you will remember only the young lady was very sweet and pretty. You should remember this. You should be able to. So both of them go together. Don't just remember this and then write surgical management as young lady was very sweet and people who were not willing for surgical procedures, nasal obturator, that is similar basic idea, is to block the nasal cavity, and these are obturators which are inserted into the nasal cavity, and that's how the nasal cavities, anterior nares are blocked, and so the patient breathes through the oral cavity, and so there is the basic idea is to give rest to the mucous membrane and then regeneration. So this is the advantages these are reversible, easily removed, allows irrigation, you remove them and you do the irrigation, avoid surgical morbidity, and uncomfortable disadvantages. And rhinitis sicca is a condition where there is mild atrophic rhinitis, seen hot, dry, dusty places, goldsmiths, bakers, alcoholics, anemics, where they increase blood supply, and crusting and bone atrophy and nasal douching is the one which helps. Try to go through the the lecture once again and see if there are any doubts. You can always come back to us and then clarify the doubts, and you can also go through your own books proper and then try to understand what is the atrophic rhinitis, the clinical signs and symptoms, the etiological practice, clinical signs and symptoms, the various investigations, the medical surgical management. Thank you.
Is it fair? Better, sir? Psoriasis. Psoriasis. We have to use this. Okay, thank you. Good morning, everybody. Today we are going to have a class on psoriasis, very important and common skin condition. It may be a spotter for your exams. Actually, I am covering most of the topics which may be there as a spotter in your final M.B.B.S. So psoriasis, it's a chronic inflammatory disease characterized by plaques. Plaques surmounted by white, loose, large scales. And if you see carefully and remove the scales, and you may see under magnification capillaries. So that's called Grata's sign. That is to be elicited bedside for confirmation of the diagnosis. So this psoriasis is a hyperkeratotic condition, proliferation of the keratinocytes without control under some triggering factors like chemokines. So these stimulation from the keratinocytes produces hyperkeratosis, thereby building up of the corneal layers one above other, forming a plaque. And this plaque is covered with silvery white scales. So this actually picture depicts left side is a normal skin, and second side you are able to see the thickening of the epidermal layer, and there is a parakeratosis, that means the persistence of the nucleated epidermal cells, and in turn because of the hyperproliferation, so naturally there will be more shedding of the cells. So usually the epidermal keratinocytes cycle is 28 days, just like a menstrual cycle. So these 28 days may be reduced to say 20 days because of the hyperproliferation. So naturally there is more shedding and more metabolic activity. So that is the reason you see these scales, lot of scales will be there on skin surface. If you see the epidemiological factors, incidence is a very common condition. We say common whenever the incidence of cases are more than 1%. So this is 0.5 to 4.5% worldwide. But in our country it's a 1 to 2% incidence. And you see it's present in almost throughout the globe, and all age groups may be involved, and it runs a unpredictable course. We don't know when it is going to get remissions or exacerbations. And if you consider the age, it's a bimodal, just like diabetes mellitus, bimodal. That means it appears early in the age group or late in the age group. So any disease process which occurs early in the age group, whether it's diabetes or psoriasis, so the prognosis is bad because the patient has to suffer for longer periods of time, so he is exposed to all types of complications. Of course, late age group, so most of the time, because at the end there is a little age, little concern, so that is the reason they don't care also, and the prognosis is also good. If you see the sex, both sexes are equally affected. But just like last time we talked about vitiligo, so today is vitiligo day. So like that vitiligo, this is also associated with a lot of stigma because of odor, disfiguration, and there may be marital disharmony because there may be smell from the hyperkeratotic lesion. A lot of metabolism takes place, or due to messy application of ointments. So they all lead to the psychological problems. And ultimately there will be involvement of joints, and some people we have seen they cannot walk also. So when they reach the final stage of arthritis, that is mutilating stage. So there is deformity of the joints, deviation of toes, and there is destruction of nails. So they are all associated with a lot of psychosocial impact, and there is a lot of not only physically they suffer, psychologically also, because since they cannot, suppose if a person has got lesions on the palms, they cannot give shake hand. So the palm will be very rough, and there is disfiguration. So all these lead to the decreased work output. They don't attend properly their work. So similarly, the marital status is also strained and leading to all the social embarrassment and severe emotional disturbance, frustration, disappointment, ultimately ending up a quality of life is compromised. So certain triggering factors are also noticed apart from the age group, what we say bimodal age. Certain triggering factors, especially the trauma. Suppose the person is repeatedly getting trauma, so you will get lesions, fresh lesions in those trauma areas. What we say is a coagulation, just like vitiligo, this also is associated with coagulous phenomena. So this trauma will be the physical trauma, or a chemical trauma, even radiation trauma also. So that is the reason the lesions are always present on the skin surface which are prone for trauma, like elbows like we sit like this. So we are supposed to examine all extensor surfaces, especially the elbows, knees, and lumbosacral area. So these are the areas more prone for stress, strain, trauma, ultimately causing hypertrophic plaques. Here hypertrophic psoriasis you notice. And certain other factors which are associated are infections. Infections, especially the Staphylococcus, Streptococcus, which act like super antigens. These super antigens trigger the autoimmunity, ultimately release of chemokines. And stress, very important. Stress always, any disease, stress increases more suffering. And alcohol intake, smoking, there are additional factors and certain metabolic factors like pregnancy, hypocalcemia. So there will be less levels of calcium. Sunlight, of course, usually we give phototherapy, most of the time it is beneficial. Drugs, especially like antihypertensive like beta blockers and antidepressants like lithium, they also act like triggering factor. Similarly, antihypertensive like AC inhibitors, then NSAIDs, antimalarials, antifungals like terbinafine, calcium channel blockers, one more antihypertensive, captopril, and it suddenly withdrawal. Suppose patient is on the steroids for collagen vascular disease. All of the sudden if you withdraw, so it also precipitates a fresh episode of psoriasis. Even if you are treating psoriasis with corticosteroids, if suddenly they are withdrawn, so they end up in complications. One of the complications of psoriasis is pustular psoriasis. So in history taking, dermatology like any other specialty, history taking very important. Whole case is built on your history. If you take correct history, the diagnosis automatically it leads to the correct diagnosis. And you should ask what are the things you are supposed to ask, whether there is a recurrence, chronicity, since how long they are suffering, or associated with any itching and any peeling of the skin, redness of the skin, or trauma producing fresh lesions. Sometimes trauma also causes subsidence of the lesions. That's called reverse coronal phenomena. Suppose the patients are undertaken for surgery. The surgery scar, sometimes it heals in other areas. So that's called reverse coronal phenomena. So then seasonal variation is there. Of course, winter season like atopic eczema, it also exaggerates in winter and it naturally improves in the summer season. And also since complications are there with the joint involvement, arthritis, so the joint may be stiff or undergo deformity in about 15 to 20% of the psoriatic patients. If you see the carefully the lesions, they are basically erythematous. To begin with, erythematous naturally because there is hyperemia to skin surface under the influence of interleukins, chemokines. So there is vascularity is increased, especially in the superficial dermal plexus. So this produces erythema. So there is reddening of the skin, and this may be shaped round to oval. And after some time, there is accumulation of inflammatory cells that produces plaques, and these plaques, when tries to heal or shed the excess epidermal cells, it causes scaling. And these plaques are well demarcated. They have got erythematous border, and these plaques will again in turn may have a hypopigmented border, round hypopigmented border. That's called Warnoff side. So scales they are psoriatic plaques. They have dry skin, thin, silvery white or micaceous scales. And sides, extensor surfaces, as I already mentioned, and Warnoff's ring, that's what I was talking about. So the psoriatic plaques, they are encircled by a pale peripheral zone. That's actually, if you see carefully, if you notice this Warnoff's ring, it's a good sign. That means the vascularity is decreasing. So once vascular supply is decreased, there is actually improvement in the lesion. So Warnoff sign, as it seems, it is a hypopigmented zone, So less vascularity, that causes hypopigmented circle around the plaque. So if you see the pathogenesis, as I told, it's all due to superantigens from staph, strepto, and some types of psoriasis also follow the upper respiratory tract infections, sore throat, like streptococcus infection. So these superantigens actually are engulfed by antigen presenting cells. So these APCs trigger the T cell type 2 helper cells. These helper cells in turn elicit, they act as the T cells and they secrete cytokines. Cytokines again in that is TNF alpha and interleukin A. They may further magnify the lesions and they in turn again stimulate secretion of round cells like macrophages, further lymphocytes, plasma cells. So that's how the pathogenesis increases. So once APC antigen presenting cells cross-link, there is the activation of the T cells, and these activated T cells secrete a lot of cytokines like interleukin 2, interleukin 6, interleukin 8, interleukin 12. So they are very important in the pathogenesis. And interferon gamma. Interferon gamma usually they are seen in the viral infections. And this in turn causes hyperkeratosis and plaque formation. So now we will go with the various types, clinical types, what we see in our day-to-day practice, how they present it. So the commonest presentation is psoriasis vulgaris, chronic plaque psoriasis, otherwise called chronic plaque psoriasis. So psoriasis vulgaris is the commonest type. That's more 90% of the psoriatic cases, they are due to this chronic plaque psoriasis, otherwise called psoriasis vulgaris. And here the lesions are oval or annular, and they are large as palm sized, and they are very well defined. Margins are well defined, of course erythematous and plaques, and usually they are situated on the extensor surfaces because of the repeated trauma covernization. And we name 90% due to chronic plaque psoriasis, confining the lesions confining to the extensor surfaces. Now about the 10% we have involvement of other sites other than the extensor surfaces. What are they? They may be scalp, genital organs like penis, scrotum, then groins, flexural areas, what we say inverse psoriasis, then palms and soles, palmoplantar psoriasis, then involvement of nail psoriasis. So different nomenclatures are given according to the sites involved, just like tinea. You say tinea corporis, which is present on the body. Tinea capitis is present on the scalp. And tinea present on the nails, we say tinea unguum. So like that. It is present on the palms and soles also. We say tinea pedis, tinea manum. So like that. Similarly, we have certain clinical types also. Not only according to the anatomic environment, certain clinical types according to the morphology of the lesions, we name them as a chronic plaque psoriasis. As I already explained, how the plaques look like, how they are actually surmounted by white scales. Then we got guttate psoriasis. Guttate means raindrop like, very small plaques will be there, just like raindrops. That's called gutted psoriasis. Gutted psoriasis prognosis is very good since they follow upper respiratory tract infection. It's very commonly seen in children. But if it is not treated in time with antibiotics, then they may develop into chronic plaque psoriasis. So that the importance of treating gutted psoriasis early. Then we have got other clinical type, rupei. Rupei means it's a, suppose if you sweep the floor and this dirty everything is gathered in the corners, that's called rupei. Rupei. So it has got just like a triangle, the heap of garbage, that's the rupei. So that shape is usually seen in the psoriasis, and you see the same thing in secondary syphilis also. So rupei psoriasis, rupei syphilis. So two is we use this rupei terminology. Then elephantine psoriasis, that means due to hypertrophy, go on producing more plaques, hypertrophy. So they are usually confined to the lumbosacral areas. It's called elephantine psoriasis. Then another clinical type is unstable psoriasis. That means they are not actually, there is no regression. Sometimes they regress and again they appear or increase in size or increase in the size. So that's called or progression of the disease from the chronic plaque to the arthritis. That's called unstable psoriasis. Then we have got erythrodermic psoriasis, otherwise called exfoliative psoriasis. This is a really emergency in dermatology, one of the emergency in dermatology. Since it is associated with a lot of vascularity, it's called otherwise red man syndrome. The whole body of the person becomes red due to vasodilatation. So there is a lot of exfoliation of the scales. So to the extent of 2 grams of protein is lost daily because of the exfoliation. So that is the reason they go into the electrolyte imbalance, hypoproteinemia. So it's a medical emergency. But the commonest cause for erythroderma, if it is due to psoriasis, we say erythrodermic psoriasis. Otherwise, most of the time the cause is not known for this erythroderma. In 50% cause is not known, idiopathic. But other causes apart from the psoriasis, there is eczema, then drug-induced, and some autoimmune disorders, they all lead to the erythroderma. And psoriasis in children, of course, I introduced already, it's very chronic and going to persist afterwards also, as it's a bimodal problem. In pustular psoriasis, this is also a complication of the psoriasis. When the patient on the steroids, when suddenly withdrawn, so they may end up in pustular psoriasis. Then we have certain atypical forms. So what we learned so far is classical types. And certain atypical forms, that is zoster form. If they are present in certain, just like herpes zoster, they are present in one dermatome is called zonal lesions or zoster form psoriasis. Then certain lesions will be seen in the scalp or seborrheic areas like beard area, retroauricular area, sternal area. So these are seborrheic areas. It's called seborrheic psoriasis. Sometimes these seborrhea may progress to psoriasis. It's called sebopsoriasis. Sometimes the atypical lesions may appear on the mucosa, especially the genital mucosa, glans penis. It's called penile psoriasis. Then sometimes involvement of the follicles, hair follicle, is called follicular psoriasis. Whenever follicle are involved, it associated with a lot of itching. Then psoriasis verrucosa. When they are thickened and warty appearance is called psoriasis varicose. Then we have another atypical form is linear psoriasis. So it's usually due to colorization. So when you scratch linearly, so it produces chronic plaque psoriasis all along the scratch marks due to coronal phenomena, otherwise called isomorphic phenomena. Isomorphic phenomena, coronal phenomena are same. So coronal is the person who first described this, and this appears usually after 1 to 2 weeks after trauma. And sometimes these lesions will be cleared following trauma in other areas. That's called reverse colonization. So this vertical line transversely what we are seeing, copular phenomena. And this is Voronoff's ring. What I was talking, the plaque is surrounded by hypopigmented ring, and it is due to vasoconstriction. That's a good prognostic sign. Voronoff's ring. And it's a classic psoriatic plaque. And in the first picture, there is involvement of lumbosacral area and very common site, elbows, knees. So this is a classic psoriatic plaque. And this is a close-up view, the second picture. So first there is a hyperemia, but background they are able to appreciate hyperemia, and it is surmounted by these chronic plaques and scales, and there are certain satellite lesions are also there. So this is how it appears, chronic plaque psoriasis, just like. So you should be very careful. Lesions are here, the lesions are large, so there is no problem. It is a psoriasis, but similar lesions which are very small in size, it may be pityriasis rosea. So very careful for studying the scales. The scale distribution is very important. Here they are very loose, white, just like onions, silvery scale, what we say. So they appear white because of entrapment of air in between the scales. So this is also one of the picture. Extensor confined to extensor surfaces. So they are white in color, these scales, due to air entrapment. So on the tail, suppose bedside, they may ask in examination, how will you confirm bedside, which is psoriasis? Why not tinea corporis or granuloma annulare, which look like, or the SY2, that is secondary syphilis. So what you say, bedside, I will sit beside the patient, take the glass slide and try to scale the silver scales. That's called grattage. What you are going to elicit with grattage? Asphyxia. Ultimately your goal is asphyxia. That means you are supposed to demonstrate bleeding points. So first you do grattage, superficial scales are removed. So after the superficial scales are removed, what you notice here, a cigarette paper thin white membrane, that's called Berkeley's membrane. And through this membrane you can appreciate the bleeding points, that's called Auschwitz sign. So this is a favorite question again in the entrances, what is Auschwitz sign? In darker skinned individuals, and the characteristic red color is absent, but the silvery scales are quite visible, readily seen. So this is annular psoriasis. Guttate psoriasis, otherwise called raindrop psoriasis. Gutta means droplet, commonly seen in children and adults following upper respiratory tract infection or tonsillitis due to beta-hemolytic streptococci, and it accounts for 2% of total psoriatic cases. The lesions are very tiny, raindrop-like erythematous patterns, and here you should be very careful with differential diagnosis with pityriasis rosea. and the number of drop lesions or droplets are 10 to 100, and a strong association with the tissue typing, that is a human leukocyte antigen CW6 is the chromosome number 6. The prognosis is good, as I already told, and the lesions resolve within 1 month, and when they are not treated in time, the antibiotic ultimately end up in the chronic plaque psoriasis or unstable psoriasis. So this is ductal psoriasis, rare droplet. This is also ductal psoriasis. The next rupioid or elephant or ostracis. The pictures which I have shown actually already, so they are all elephant and rupioid. Ostracis. Ostracis means it's a hyperkeratotic plaque. Just like you see the ostracis in the seas, where inside there is a ester will be there. The outer shell is called ester. So inside you may see pearls or a small frogs. The next clinical type is palmoplantar psoriasis, very difficult to treat it and lot of association with stigma, and most of the time they are well defined, less scaly because repeated trauma. For everything we work with hands and foot, so when repeated trauma is there, less scaly, surface becomes little smooth, but you may notice fissures. That is most important, fissures are there. You will notice 3 forms of palmoplantar psoriasis. One is diffuse hyperkeratotic plaque. Second is erythematous patches or plaque. They are studded with small, minute, superficial pustules. Then there will be a discrete scaly plaque. So diffuse plaques, discrete plaques, and erythematous patches. There are 3 forms of palmoplantar psoriasis. So there are well defined scaly plaques on the palms. It's not that easy, they look so simple, but there are so many other conditions that look like palmoplantar psoriasis, like hyperkeratotic conditions, like epidermolytic hyperkeratosis. It's a congenital disorder, like one of the variety of ichthyosis. And similarly, such lesions may be seen in eczema, hand eczema mainly. So this is plantar psoriasis. You can notice hyperkeratotic plaques with fissures. So another variety, clinical variety, is generalized pustular psoriasis. So there is development of pustules, they are also very minute, they appear acutely, commonly seen some stressful conditions like pregnancy, then children also, and they will be localized, but not seen on the hands and feet. They will be annular and they are exanthematous. Here we should be very careful diagnosing some acute cutaneous drug reaction, where we have one condition called AGEP, acute generalized exanthematous pustulosis. Very difficult to actually differentiate. Always keep them on their history of drug intake will be there. That's also acute, this is also acute. Here they give history of psoriasis existing in the past. So this is a pustular psoriasis. There is a erythematous background. If you see carefully, erythematous background on which there is a tiny grouped pustules, pustular eruption. They will be focal or generalized. Palmoplantar pustulosis. So the same thing. It's a repetition. So it's acute palmoplantar pustulosis. Acute generalized pustular psoriasis, generalized pustular psoriasis. You may notice one jumbush type of pustular eruption in the cornea. In the corneal layer, you will notice the neutrophil migration. So these neutrophils, they get converted to the pustules. So that's called one jumbush type of psoriasis, psoriatic lesions. There are multiple on the erythematous background, tender plaques studded with pinhead-sized tiny sterile pustules. They coalesce to form lakes of pus. There will be, since it is a pus, lakes, there will be systemic toxicity, and usually it resolves in 2 to 3 days. So this is also generalized pustular psoriasis. So these, though they are pus, they are sterile, there is no bacteria. And there is a central pustule, there is a sign of healing with peripheral erythema. Then we have got most important dreadful complication of psoriasis, that is erythrodermal psoriasis or exfoliative dermatitis. Exfoliative dermatitis is terminology used in UK, whereas erythrodermic psoriasis used in US. So this is a generalized form, total or near total erythema with superficial scaling. This accounts for about 20% of all erythrodermic diseases. Psoriatic erythroderma accounts for 20% of all cases of erythroderma. So this total erythema, red man syndrome, what we say, a lot of exfoliation, so naturally ending up in the hypothermia, hypoproteinemia, electrolyte imbalance. It's an emergency, medical emergency. We have to replace electrolytes, we have to replace the proteins and treat bacterial infections, febrile infections. So erythrodermic psoriasis involves widespread areas and accompanied by burning sensation, pain. Whenever there is erythema, there is a burning rather than the itching. And the scales are there, or involvement of follicles, then itching will be there, they are burning. So this results from the exacerbation of the unstable psoriasis. Sometimes abrupt withdrawal of the steroids and fatal. Then we have got other types, scalp psoriasis. So scalp psoriasis, when the lesions, similar lesions like chronic plaque psoriasis lesions are present on the scalp. Usually, we like to differentiate it from seborrheic dermatitis or dandruff, commonly seen. Dandruff, otherwise called seborrheic dermatitis of the scalp. So this is one of the nearest differential diagnosis for scalp psoriasis. Another terminology used is for dandruff, pityriasis capitis. And we say corona psoriatica when there is a spread of these erythematous plaques beyond the hairline. So they appear like here. That is the diagnostic feature. Blindly you can say when there is a corona psoriatica, it is psoriasis. The plaque extend behind the hairline, either on the sides, back or frontal area. Corona psoriatica. So on the back, and then there are all the seborrheic areas. So in the excess scales, it's called pityriasis amiantasia. Pityriasis means scales. Amiantasia means it is just like asbestos. Like asbestos sheets, there is overlap of the scales in psoriasis. Again, we should be very careful in differential diagnosis from tinea capitis. And then another variety we got male psoriasis. It we see in 20 to 50% of psoriatics, the common we find the pitting. Pits will be there on the nail plate, and there will be damage to the nail plate called onycholysis, and there will be separation of the nail plate from the nail bed, it's called onychorexis, and there is a subungual hyperkeratosis, and since there is hyperkeratosis beneath the nail plate, there is crumbling of nail plate, or sometimes you notice ridges, grooves on nail plate, and discoloration, yellow discoloration, or sometimes splinter hemorrhages. So there are the nail changes. Usually the hind nails are commonly involved, more commonly involved than toenails, and its incidence is more when it is associated with arthropathy. And there is a proximal portion pitting and middle and distal leukoplakia, all fleck phenomena, that is oil drop sign. There is accumulation of parakeratotic material in nail bed, seen throughout the nail bed. That is oil fleck phenomena or oil drop sign. So here depicting both nails, that is the toenails as well as fingernails. You can see pits, irregular pits. So sometimes the pits may be seen in eczema also, so be very careful. So here this oil drop in the single thumbnail, you can notice a hyperpigmented patch in the nail. So that's called oil drop sign. So there is a ridging, vertical furrows, pitting, discoloration, especially both proximal and distal, and there is hyperkeratosis. The nail bed is laden with hyperkeratotic tissue, causing the eruption of the nail, subungual hyperkeratosis. Then we have got another type, flexural psoriasis or inverse psoriasis. The common site is groin. Sometimes there will be involvement of axilla, gluteal cleft, inframammary fluid. So these should be differential diagnosis closely with the tinea cruris, tinea corporis, because that it is seen in the same areas, tinea cruris. Here there is they are smooth comparatively because of the adjacent areas, a lot of moisture will be there, that the reason there will be glycerin will be there, and there will be fissures also, and they are less scaly because they are subjected to the close contact, so scales will not be there much. So here we should be very careful in differential diagnosis from candidal intertrigo or other dermatophytic infections like tinea pedis. There also you will find inverse psoriasis. So this is typical what you are seeing in inverse psoriasis, and that margin is extending bilateral. So this is classical psoriasis, inverse psoriasis, but if in water there is nothing wrong even if you diagnose it as a candidal intertrigo, because there is a maceration in the gland. Smooth clearing or block. So again one more picture in the female. Groin region involvement and extending onto the vulva. Next complicated psoriasis, psoriatic arthritis. Remember, it's not exactly complication of chronic psoriasis. Psoriatic arthritis per se may appear for the first time without any plaques on other side of the body. And it may coincide simultaneously with the plaque type of psoriasis, or it may appear after the treatment of plaque psoriasis. So commonly, simultaneously seen most of the time, but doesn't mean it's not seen independently. So it is seen in around 5 to 10% of psoriatic patients. And we got various types. The commonest type is oligo-articular. That means only single joint is involved. Oligo-articular in 70% of the cases. But the classical picture you see when there is involvement of distal interphalangeal joint involvement, the second more commonest is called classic dip joint involvement, producing swan neck deformity, like swan neck deformity. Then rheumatoid type, so bilateral. Then there is psoriatic spondylitis, there is lumbosacral spine involvement. And lastly, arthritis mutilans, there is a deformities of the bones. So, psoriatic arthritis will be associated with tenosynovitis. Then enthesitis. Enthesitis is inflammation of the tendon where it gets inserted onto the bone. That's called enthesitis. And there is a osteolysis and new bone formation, and there is a joint fibrosis causing ultimately ankylosis, that is restricted movements. This is classical psoriatic arthritis. Distal interphalangeal joint is involved, producing swan neck deformity. So same thing with dactylitis as well as the inflammation of this interphalangeal bone is called dactylitis, and the swan neck deformity also there. This is mutilans. There is actually just like leprosy patient you can notice. There is resorption of the bones and deviation of fingers. Then this is dactylitis. Again, inflammation shaft of the bone. Then there is the enthesitis, especially tendoachilles attachment to the calcaneum. And on X-ray you will notice this penicillin cup sign, because of that you can see the narrow arrow showing there is a cup-shaped deformity, and this proximal bone is like a pencil shape. It's trying to fit into the cup, it's called penicillin cup. And then the ankylosing also because of the synovitis and arthritis. Then we got another variety, penile psoriasis. So it's present in 2% of psoriatic plaques. The common site is glans penis. Glans penis. Sometimes there is a solitary patch, but it's less area which appears on the mucous membrane. So mucous membrane, when the lesions are present, it's a moist area in compared to the dry area. Other areas are dry, but here is moisture in there. So naturally less scary, but color and so well-defined margins they are retained. Here you have to be careful in differential diagnosis from erythroplasia of Curette, that is in situ carcinoma of penis, erythroplasia of Curette, or Zu's plasma cell balanitis. Only histopathology will actually give the correct picture, correct diagnosis. Clinically, they all look similar. So, whereas psoriasis is clearly we see erythematous base surmounted by loose, white micaceous. Micaceous means that yellow scales are there. Both type of scales are here misaligned, and the glands, coronal sulcus, under surface of the prepuce, and some plaques are there in the shaft of the penis also. So this is penile psoriasis. In special group we have psoriasis in children and HIV patients. In children, usually the plaques are not that thick as in adults. They are less scaly. The lesions may be confined to the diaper area, flexural areas, and there will be face involvement. Usually in adults, there is no involvement of face except the corona psoriatica, but face involvement is commonly seen in the children. Then we got psoriasis in HIV. It's acute onset, severe flares will be there, prognosis is very poor. So psoriasis in children, and second picture in psoriasis in HIV patient. So facial psoriasis rarely involved, as I told. Seborrheic psoriasis, this we already talked. Seborrheic psoriasis. Then zonal psoriasis, this also we talked. Follicular psoriasis over. Psoriasis vericosa. So these papules are dome-shaped, hyperkeratotic plugs. So they look like warts rather. These are the complications like erythroderma, pustular psoriasis, psoriatic arthritis. These are the three complications in psoriasis. This is erythroderma, with total involved erythematous skin, then scales all over the body, and certain assessment parameters we have to assess the severity of psoriasis and to monitor the treatment also. That is body surface area, total body surface area involvement with the plaques, that is called psoriatic area severity index. So depending upon the intensity of symptoms, sites involved, duration of the disease, and clinical type and presence of arthritis, and tolerability of the previous treatment like methotrexate and its response, and the impact of the disease in daily life. So these are all parameters we check for, and this is the psoriatic area severity index, and it helps in the monitoring of the response to the treatment. And usually we select 4 sites, that's the head, upper limb, trunk and lower limb. We got each is involved, how much percentage. So the maximum you can see the maximum score is for lower limbs, followed by the trunk, then upper limbs, lastly head. Then morphological scoring, whether it's only erythematous or associated with undulation, plaque formation or desquamation. So depending on that, we score them 0, that is no lesions, 0 score, and mild 1, 2 moderate, and 3 severe, and 4 very severe. And differential diagnosis of psoriasis, and I told whenever I was speaking the subtypes of psoriasis, the mainly you should remember the granuloma annulare, then nummular eczema, lichen planus, pityriasis rosea, pilaris, then seborrheic dermatitis, tinea corporis, and pityriasis lichenitis chronica, candidiasis, secondary syphilis, and acute cutaneous drug reaction. So these are all differential diagnoses. This is seborrheic dermatitis, and the secondary syphilis, SY2. So that is the reason we should do for all such cases radiology a must, because it's a great mimicker. So this is tinea corporis, tinea cruris, and histopathology. So most of the time it's a clinical diagnosis, but whenever they are in doubt or for the sake of postgraduate students, we do biopsy. So in biopsy what you see, hyperkeratosis, parakeratosis, agranulosis, absence of granular layer, and there is microabscess called Monroe's microabscess in the stratum corneum, and there is regular elongation of reed ridges, and which appear like camel foot shape, regular reed ridges, and there is suprapapillary thinning of stratum malposition. There is again accumulation of pustules in the stratum malpighi, they are called spongiform pustule of Kogols. Then there is a dilatation and tortuosity of the capillaries and the superficial dermis, and there is a perivascular inflammatory infiltrate in the deep dermis and superficial dermis. So this is the first picture. You can notice hyperkeratosis, and there is a parakeratosis, the thick line. This hyperkeratosis, parakeratosis, and this microabscesses. This is Kogols abscess, and here you can notice the Monroe's abscess, and this is suprapapillary thinning here. Okay. And then the hypervascularities. Okay, here you can notice hyperkeratosis, orthokeratosis, parakeratosis, then acanthosis. Acanthosis is proliferation of all the epidermal layers is called acanthosis. Then suprapapillary thinning, the dilated tortuous capillary loops, and upper dermal lymphocytic infiltration. Same thing in detail, well labeled. So first is acanthosis, here acanthosis. Second is the abscess, Monroe's microabscess in the stratum corneum. Then it's a parakeratosis, thick line, number 3. And 4 is spongiform pustules of Kogols. Here you can notice in the stratum malpighi. Stratum. Papillary. Then it's a dilated and tortuous capillaries. In the dermis, superficial dermis, you can see dilated capillaries. And there is a accumulation of lymphocytic infiltrates around the vessels. Treatment is basically a dry lesion, so you have to break it by providing moisturizers. So moisturizers are mainstay of treatment. Since it's a hyperkeratotic lesion, so you have to reduce the hyperkeratosis by giving steroids. So emollients, that is moisturizers and topical steroids, are mainstay of treatment, the first line drugs. If they are obese, ask them to shed their weight. If they are alcoholics, ask them to stop taking alcohol, smoking, and they should stop receiving traumas or any irritating agents, and they should reduce stress also. They should actually sunlight and sea bathing improves psoriasis. So the stepwise treatment of psoriasis, the first topicals are enough, corticosteroids and moisturizers, and second stage we go for the calcipotriol and anthralin and cotal, and third stage we go for the phototherapy, that UVA, UVB, and lastly we go for biologicals. It's a new treatment is biologicals. Secukinumab is the IL-17 antagonist, so that is the drug of choice for psoriasis. That is expensive, it costs about 25,000 for each injection. What we do is cyclosporin, of course middle class people, oral cyclosporin. It's actually acute conditions is very useful. It immediately acts and controls the clots. So cyclosporin is actually crisis buster. What we say, crisis buster. But in poor man's, especially in our hospital, we use methotrexate. It's very cheap, weekly treatment. And but palmoplantar psoriasis, we give retinoids. Retinoids are the treatment of palmoplantar psoriasis. So topical therapy, emollients, corticosteroids. How I told. So they respond with topical steroids within 2 to 3 weeks. So that should be continued even if you are giving other modalities of treatment also. These topical emollients, moisturizers and topical steroids may be continued till their acute symptoms are relieved. Coal tar, of course, this is all messy treatment, we are not using anything because it stains the clothes. So old treatment, coal tar and diphenol. Diphenol causes irritant dermatitis, that is the reason we don't use. Phototherapy, yes, we are using here UV chamber is available with us and mainly useful for extensive psoriasis. UVA combined with Soralens is a power. When UVA is combined with Soralens, Soralens means it's a chemical agent which takes sunlight, UVB rays from the atmosphere and imparts the heat to the. So heat ultimately is the treatment, area of treatment. So UV rays are more preferred than UVA. But when UVA are there, are those combined with Soralens. Then we have got systemic agents, mainly the methotrexate and cyclosporine. Cyclosporine, expensive and compared to methotrexate and associated with some renal complications because of a precipitation of hypertension. So you have to monitor blood pressure. And methotrexate is a wonderful drug with long history of usage throughout the globe. So poor man is very cheap. So it's a weekly treatment available. The only thing is you have to monitor regularly the liver function tests and bone marrow functions because it produces hepatitis and bone marrow suppression. So that you have to look for. Acitretin is a retinoid, oral acitretin is available, a dose of 25 milligrams. So it's a very good drug for pustular psoriasis as well as palmoplantar psoriasis. Acitretin is contraindicated in child-bearing age group. So biologics, mainly the old biologicals, we are giving actually pre-filled syringes are available, called efanesumab, etanercept, infliximab. So they are the old drugs. Now we actually give secukinumab, that is the latest drug. Specifically, it prevents IL-17. Prognosis, if you treat adequately, prognosis is good. Of course, you can give only remission, but again they may relapse at any time, and most of the time they relapse, but you have to treat adequately in time and avoid the stress. Be very careful about recovery disease. They don't respond, and immunomodulators you cannot give. So acitretin is good choice for retroviral infection. So when you should refer, when there is a failure of the routine treatment like emollients, keratolytics, topical steroids, or natural sunlight, you refer to the dermatologist. So in summary, it's a lifelong condition. Recurrence are very common. There is a morbidity associated with this condition, and some cancers may develop, or arthritis and arthritis mutilans, sometimes hepatitis. And it's very difficult to predict who are going to get relief with the treatment or who are going to worsen. You have to see carefully, and accordingly you will have to rotate the drugs from first line to second line to third line to fourth line. So you can say after the counseling aspect is very important. You must tell them it's a lifelong therapy. In the beginning only you must tell, so that they will not be disappointed afterwards. Long-term treatment, just like homeopathy, so you have to prepare mentally these patients. So holistic approach is essential, and psychological boost and improve the quality of life. The combination of drugs are important rather than a single therapy. With this I end. Thank you.